orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Right. Very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Kanduja. I'm a consultant orthopedic surgeon in Cambridge, UK, one of the founders of SICOT Pioneer and also the current president of SICOT. And it's an absolute pleasure to welcome all of you logging in from various corners of this world into this important webinar. Now, we started this when it was COVID, and you'll be pleased to know that it's our 99th event today. So we're almost reaching a century. And we've had over 125,000 views from 110 countries all around the world following us on this. So big thank you for the 10,000 people who've been actually doing this on a regular basis. Now, today's webinar is focused on slipped capital femoral epiphysis and is the third pediatric orthopedic committee webinar. Much thankful to the efforts of Alaric for actually getting this going. And our two chairs today, one from two corners of the world, Basel from Texas in the US and Daria from Moscow in Russia. Now, we'll try and make this as interactive as possible for you. Do post in your questions. A big thank you to all the stellar faculty who've actually given up their time over the weekend to do this. And with that, I'm going to hand it over to Alaric and to our chairs to take over the proceedings. A big thank you once again.
Thanks, Vikas, for that very kind introduction. If I knew that this was going to be the 99th one, I would have postponed it to one more so that we could have had the century. But it's wonderful to see where SICOT Pioneer has come over the last 5 years, all thanks to the efforts made by the SICOT leadership. My name is Alaric Aroojis, and I'm the chair of the SICOT Pediatrics Committee. And I welcome all of you today to this excellent webinar where it's going to be a wonderful learning experience on the topic of slipped capital femoral epiphysis. Out of all the things that we treat as pediatric orthopedic surgeons, I can't think of any topic that has had such a paradigm shift in the understanding of the biology, the biomechanics, and the treatment of a condition as slipped capital epiphysis has seen in the last 2 decades or more. And a large part has been due to the amazing work done by the group from Switzerland, led by Professor Gans, who has shown us the importance of the blood supply of the femur, and therefore has opened up new avenues for surgical hip dislocation and various other approaches that have really modernized our thinking on slipped capital epiphysis. Today, as Vikas has said, we have a wonderful, stellar faculty, all of which are known experts in the field of hip preservation. And I'm sure they're going to really regale you all with their expertise and their experience in this field. We have changed so far ahead from what was the gold standard of treatment of slipped epiphysis, which was putting in an in-situ screw, to now more modern techniques of raising a retinacular flap, doing a modified Dunn osteotomy, and capital realignment in a very safe and standardized manner. There are also tips and tricks in how to avoid complications, which I'm sure our faculty are going to share with all of you. And we also have a very interesting session on the management of the post-slip deformity using modern techniques of arthroscopy to avoid femoral acetabular impingement. So without any further ado, I welcome all of you once again to the webinar, and I hand it over to our two chairs, Basel Touban from the US and Daria Pavlova from Russia. Take it away, guys.
All right, thank you all for attending. I'm going to go ahead and share my screen. Can you all see my presentation?
Yes.
All right, so my name is Basel Touban. I'm a pediatric orthopedic surgeon at Texas Children's Hospital in Austin, and I focus on hip preservation. My brief talk is designed to be a primer on a challenging entity we all know as SCFE. So SCFE was recognized as early as the 16th century, with Ambroise Paré writing that the epiphysis of the head of the femur sometimes becomes disjointed and separates. Jean-Louis Petit recognized that the slipping can occur only in young subjects where the cartilage has not yet ossified. And in his landmark article, Mueller described the history and physical examination findings associated with SCFE that are in use today. By the early 20th century, three common etiologic theories emerged. The trauma theory was quickly discounted because there was often little history of trauma. In many cases were bilateral. Sangenheim's anatomic study showed abnormality in the epiphyseal cartilage, reinforcing the diseased cartilage theory. Hofmeister proposed and later Kirmissen reinforced static theory by showing an association with obesity, essentially contributing to our modern understanding of SCFE. And as surgeons, we love to classify things. So early on, the duration of symptoms was used to classify SCFE into acute if symptom duration was less than 2 or 3 weeks, chronic if more than 3 weeks, and acute on chronic if there was a change in a pre-existing slip. This classification is limited by the inaccuracy of history often obtained from patients, and it does not really correlate with intraoperative stability. The slip severity classification measures the amount of the epiphyseal displacement relative to the neck. There are multiple variants in the literature, and a pre-slip can be detected by physeal whitening or irregularity on plain radiographs or physeal edema on MRI. This, however, is limited by reliance on high-quality images and has a moderate reliability between observers. The loader classification was introduced in 1993 and has been shown to be important in relation to the prognosis. It is based on the ability to bear weight. However, the most feared complication of AVN occurred in 50% of unstable slips versus 10% stable slips, according to Loader's study. This classification is limited by its descriptive nature, and faculty on this webinar have shown it to not correlate with intraoperative stability. The Southwick angle is the most commonly used classification. It is measured on a froglateral view and based on the angular deformity between the long axis of the shaft and the epiphysis compared to the normal side, and has 3 grades. Its strengths include good inter-observer reliability, good correlation with slip severity, and utility in surgical planning, but is limited in its reliance on good radiographic positioning, the experience of the observer, and it has limited use in mild slips. And as a community, we desire to find a perfect classification that predicts prognosis and guides treatment. And to that end, some groups have done some outstanding work. The group in San Diego assessed whether preoperative CT scan can determine stability. And they found that CT predicted stability exhibited 78% concordance with intraoperative stability and concluded that CT is comparable to Lotus classification but improved accuracy. However, the numbers of patients in that study was small. Another group in Boston assessed the relationship of epiphyseal tubercle to its socket for predicting stability and noted that it is reliable and correlates highly with the Southwick and Loader, but not with the chronicity classifications. And they concluded that further study is warranted. So in conclusion, SCFE remains a challenging entity and the existing classification systems are imperfect. However, novel classifications are promising. As things currently stand, it is important to have multiple tools in your toolbox to deal with SCFE. And with that, I'll turn it over to my dear colleague, Daria Pavlova from the Russian Federation, who will introduce our first speaker. Thank you. I'll stop sharing.
Thank you very much, Basil, for a short reminder about classification. And it's a great honor for me to present the first report, which Mark Eidelman will tell us. And this is a report about very important basic topic. Mark is a head for pediatric orthopedic and Rambam Hospital Science 20. He is a professor of Technical Faculty of Medicine in Haifa, and Mark will speak us about in-situ fixation fears and pitfalls. We will start. Mark, listening to you.
Okay, thank you. I share my presentation just a moment. Could you see it, please? Could you see my presentation?
Now, not.
No? Now?
Yes, we'll see your screen.
Okay, thanks. So, thank you for having me. I would like to share what I know about pediatric in-situ and sleep capital femoral epiphysis. I'm pediatric orthopedic surgeon from Rambam Hospital in Haifa. And more peaceful day. I hope that you can join us one day. So, what is the indication for pediatric in-situ? It's ideally for mild sleep capital epiphysis. Ideally, but in all standard textbook, it describes for all types of sleeps. So what means, what means pinning in situ? Obviously, no reduction. Historically, overnight traction indicator for unstable sleep. And non-intentional reduction happened all the time during transfer to anesthesia. Is it desirable? I don't know, but it happened. So shortly about anatomy of the sleep. It's different from femoral neck fracture. And think about of insertion of the needle inside of the tennis ball all the time, that you're not in the center, you cut out of the ball. Look on this picture. All three screws in the same position on the AP view, but on the lateral, only pin C is acceptable. This is a nice example, the difference between femoral neck fracture and sleep capital femoral epiphysis. Now about position. Supine, we are not using any bumps. For last 20 years, I'm using radiolucent table. For me, it's much easier setup, but I started with traction table. You can use either, both of them. For me, radiolucent is pretty easier and better quality of the lateral view. C-arm should be perpendicular to the hip and monitor near the patient head. So you have to mark on the AP view center of the epiphysis. And for the lateral view, this is important. You have to flex the hip to 90 degrees and abduct to 45. Remember, in more severe sleep, the entry point is much more proximal. For this, in severe sleep, I mark where is the pulse of the femoral artery. This is ideal position of the guide wire on both view, on the AP and the lateral, in mild sleep capital femoral epiphysis. And my skin entry point should be intersection of the AP and lateral view. It's about 1 centimeter incision, the hemostat, spread soft tissue to the periosteum. We are using fully threaded screw. It's much easier to remove them. 99% in single screw, double only for unstable. Remember to be in the center position on both view. And also, don't forget about Brodetti artery, not to injure this. This is this lateral epiphyseal arterial group. And remember, not to be in the posterior superior quadrant of the epiphysis. If you cheat a little bit, it's better to be inferior from the center, but never superior on the epiphysis of the femoral head. So drilling or taping, to be honest, I'm not using it because we are using 6.5 millimeter screw in children less than 12-year-old, 7.5 in children more than 12-year-old, and they are both these screws self-taping, self-cutting. But in the exclusively harder bone, you can also drill at the beginning. 2 screws for unstable sleep, as I said. Beware of wire, guide wire protrusion or screw inside of the joint. Never bend the guide wire, especially when you're taking the lateral view. Stop screw at least 3 millimeter, better more, from articular surface. For the stability of the fixation, you should have 4 or 5 threads inside of the epiphysis. Look at this. For me, it's ideal position of the screw. It's fully threaded, and we have 5 threads here on the lateral and also on the AP view. This was mild sleep. It's easy. But this one is a 12-year-old girl, one of most severe, acute on chronic stable sleep. So I hesitated what to do, and I did also pinning here. Look at how it looks. She had 6 months history of limping and recently severe pain. So this is my screw, and I pee on the lateral, and I combine this with intertrochanteric flexion osteotomy. And look the position of the leg before and morning after surgery. This is the video that I show how I'm doing it. Look at the difference between severe and mild sleep capital femoral epiphysis. Mark the line on the skin. Look at the femoral artery because this is severe sleep. So I feel where is my starting point on the AP. Insert few millimeter. Then we have to check on the lateral position, flexion of the hip, 90 degrees, abduction 45, okay? Look on the monitor. So now my partner explained me that the ideal position should be in different position. I have to change the entry point. When I did it, 1 centimeter incision, spreading the periosteum to the periosteum with the hemostat. Okay. This is the depth gouge. It's better to see on the lateral position, just few millimeters should be outside of the bone in order not to cause impingement with the screw. Okay, now it's important. Okay, when you insert the screw, all the time look on the monitor. Take multiple shots in order not penetrate articular surface. And this is crucially important, live fluoro, in order to see where is your screw. And it's in the center position. Okay, what not to do? This is what I call adult femoral nextile fixation. It's 2 screws in superior quadrant and see what happened because of the wrong insertion entry point. Pitfalls, it's better to reveal the position of this screw inside of the operating room than outside. Complications. Controlize described because of the screw penetration, like here. AVN usually happens because of the unstable sleep or insertion of the screw in the posterior superior screw placement. Remember, lateral epiphyseal group on the so-called Prodetti artery. AVN in unstable sleep up to 50% and 0 in stable sleep. My take-home message, be precise, central position of the screw is crucial, prevent inadvertent guide screw placement, and when patient painful after surgery, immediately do CT in order to exclude wrong position screw. Thank you very much for your attention.
Thank you very much, Mark, for your important message. We will discuss some issues at the end of the short block called treatment of acute epiphysiolosis. And now we will continue. And the next message will be presented by Kai Ziebarth. Kai is section head pediatric orthopedics and traumatology of the University Hospital of Pediatric Surgery in Basel Bern, and the president of Pediatric Orthopedic Expert Group of the Swiss Orthopedic Society. Kai will share with us unique experience on the topic modified Dunn procedure, pierce and pitfalls. Kai will listen to you.
Thank you very much. I will try to share my talk with you now. Let's see. Can you see everything?
Yes, we see your screen.
Okay. Yeah, thank you very much for the introduction. My name is Kai Ziebarth. Greetings from Switzerland. It's also hot here in Switzerland. I have no disclosures. And this is my talk of the modified Dunn procedure and the technical pitfalls and pearls. So as you all might know, the modified Dunn procedure is based on the original publication by Dunn, published in 1978, and Professor Ganz modified it with his surgical hip dislocation approach that he published in the 1980s. And then later, Ganz and Leunig published the extended retinacular soft tissue flap, which enabled us to put the head from the femoral neck. And the big advantage of this procedure is we can judge the real dislocation of the femoral head and also the stability. We can anatomically reduce the femoral head under protection of the retinacular vessels. And of course, we can treat also the joint damage which might occur. The indication for this approach is mainly the severe dislocated acute or chronic SCFE. So everything started with a positioning. And, I always recommend that one of the OR team members should be around when the patient is positioned, because if the patient is sleeping and paralyzed, the people can move the legs, and if the SCFE is unstable, the retinaculum can rupture and the blood supply is disturbed. So anybody should be very cautious when positioning the patient preoperatively. And on the right-hand side, you see the patient already draped. Note the back in front of the operation table where we put the leg while dislocated it out of the socket. The incision should be around 15 to 20 centimeters, depending on the size of the patient, and don't be too short with your incision because you have to have a very good overview. Then you split the fascia lata and you put the leg in extension of the hip and in abduction, and then these so-called Gibson. And now you have to identify all the landmarks that you can see here. Of course, also the piriformis tendon, because this is the border and you shouldn't go below this muscle tendon. Then you take down the greater troch, and I always recommend before I take down the greater trochanter to go or establish the interval between gluteus minimus muscle and piriformis muscle. And then you can take down the greater troch, because if you do this first, then you have bleeding from the bone, and then it's sometimes hard to identify all the anatomical landmarks. Here you see the drawing. Now you bring the leg in the figure of 4 position, which means external rotation and flexion in the hip. This releases all of the muscles that you have to release from the joint capsule. And as I said before, don't go below the piriformis tendon, because the MFCA artery comes below the piriformis muscle. And if you go down there, then you can harm the vessel. Then you see the capsule circumferentially. You open up the capsule in the line of the apophysis. And we do this in a Z fashion. You can do this in a T fashion as well. And now you can judge the stability of the femoral head. And if the femoral head was not stable, fixed on the femoral neck, you have to pin it before you dislocate the femoral head out of the socket. And also you should drill a hole in the femoral head to see if the blood supply is still there. Now you can dislocate the femoral head out of the socket with this kind of hook that you place around the femoral neck. You see this below this picture on the left-hand side. You can subluxate it. The assistant on the opposite side of the table takes the leg in his hand. Then you can cut the ligamentum capitis femoris, and then you dislocate the femoral head, and then you can see all the structures of the hip joint. And now you can judge if there is a cartilage damage or if there's a labral tear that you have to fix before you continue your modified Dunn procedure. Now the most important part, the extensive retinacular flap, has to be developed. You see here intraoperative pictures of Professor Ganz doing this flap. And you see it's at this age group, it's quite easy to do this because the periosteum is very thick. And in the anterior portion of the femoral neck, it's very loose. And you can develop this flap really distally up to the great lesser troch and medially to the ligamentum of Weitbrecht. The posterior retinacular flap is a little bit more demanding because you have to break out fragments from the stable portions of the greater troch. And you can see it here also in this video. You have to break fragment by fragment from the former stable greater troch, and then you see how the tension of the periosteum releases. And this gives the periosteum and also the vessels more freedom. And sometimes the femoral head is not perfused or shows no bleeding, but afterwards you see that the femoral head again is bleeding. If you have finished your retinacular flap circumferentially around the femoral neck, you are able to take down the femoral head from the neck. If you are in an unstable situation, you have to just remove your K-wires for the prophylactically fixing, and then you can just push the femoral head from the neck. If it was a stable case, then of course you have to osteotomize the former physis to bring the femoral head from the femoral neck. Afterwards, you have to remove, and you have always callus formation, and you have an oblique femoral neck, and you have callus formation, and this is an obstacle for reduction of your femoral head, and you have to remove this. And again, you can see this here by this video. Again, Professor Ganz performing it. You see the femoral head is released from the femoral neck, pushed down in the socket so that you see the entire femoral neck, and then you can release the callus from the femoral neck later on. Here you see on the left-hand side a picture intraoperatively before, and on the right-hand side after trimming the femoral neck. The final step is just to remove the remaining physis out of the femoral head, and then you can reduce the femoral head on the femoral neck, and you have to make sure that there's no tension on the periosteal flap, because otherwise you bring the vessels in danger. This is the intraoperatively result after reduction. And if you have this situation that you do the capsulotomy in an unstable case and the femoral head is not bleeding out of the drill hole, continue this operation, because as I said before, sometimes the vessels are kinked or just spastic, and they will recover when you do the periosteal flap, as long as they're not ruptured or iatrogenic destroyed. This is a pre- and post-operative picture of the modified Dunn procedure for a severe slip. Let's just remember what I said before. The pre-op positioning is very crucial. Your incision shouldn't be too short. Judge the stability intraoperatively and preserve the femoral head blood supply by fixing the unstable femoral head. Develop the flap long enough. Don't cut in the periosteum. The periosteum must be preserved, and you have to resect the callus formation to have no obstacles for the head reduction on the neck. Thank you very much.
Okay, thank you very much for your beautiful presentation. But unfortunately, we have a bit late, so we will discuss all questions in the end. And I am pleasure to head over to floor to Basel, who will introduce the next speaker.
Thank you, Daria. So our next speaker is Dr. Prasad Gourineni, who completed orthopedic residencies both in India and at Northwestern University in Chicago. He currently serves as the Clinical Associate Professor of Orthopedic Surgery at the University of Illinois. He is the chairman of Amara Hospital in India and the chief of their Hip Preservation Center of Excellence. He is going to share with us his experience with the modified Dunn procedure done with arthroscopic assistance.
Thank you, everyone. Thanks for the opportunity. So this technique, to start off with, it's not... Can you see my presentation? Is everything good, Basel?
Yes, that's good.
Yes.
Yes.
So I want to start off today with a disclaimer. This technique is not recommended routinely even by me after doing a few cases. So we did these procedures in 2011. After that, I found out that Akari published it in 2010 and Roos in 2016. Basically, you do two portals, two small holes for screws, no GT osteotomy. First case, I'm going to show two cases, both at 12-year-olds with right SCFE, stable. This girl was thin, not heavy at all, has a nice long neck, looks like a moderate to severe slip. I measured 40 degrees on this view. This mother wanted me to do something minimally invasive. So we offered her arthroscopic Dunn. Look at how severe this is. The initial 40 degrees doesn't mean anything. This head cannot go any more posterior, right? It's a severe slip against the neck. So the procedure was one portal for the scope and the other portal for the burr to shave this part of the neck, like a wedge resection. We were able to remove the wedge without disturbing the periosteum and the blood supply. Then reduce the head to the neck. The gap could not be closed manually initially, so we put guide wires and then push the shaft against the head in the socket and then lagged the head to the socket to close the gap. So this is a big limitation, this arthroscopic technique. With open, you're holding the head and putting it back in place, but here, you need to maneuver the distal fragment to reach the proximal fragment. Here are the two screws holding it. A little residual posterior slip, but her deformity went away, clinical deformity. This is the bone scan. Luckily, the right hip showed even increased uptake compared to the opposite hip. So the blood flow is actually increased post-operatively. So she healed, she did well, though there's some collapse of the screws coming back, but she didn't have any displacement, did very well. So we were very encouraged with this result and offered it to the next patient. She was also 12 years old, somewhat obese, typical of SCFE. As soon as I put her on the table, without even distraction, her hips looked somewhat loose. But I didn't know the consequences, so we chose to proceed. Again, a moderate to severe slip. Much more severe as you look at it in a different view. Same procedure done again with the burr, removing an anterior wedge type bone and remove the callus from the neck. Two screws to hold it. As you can see, even at this stage, the femoral head is subluxated with no traction. So we watched this a little bit. Bone scan was again good. Increased blood flow compared to the opposite normal side. So we know now that blood flow is not an issue with the arthroscopic Dunn osteotomy. But the limitation is, because of subluxation, she developed a little bit of chondrolysis, but that resolved over time. So lucky that she did well, but I was discouraged after this operation, so I do not offer this routinely unless somebody really asks for it. In conclusion, this is like a Dunn osteotomy done without surgical dislocation. Same complication, you need to shorten the neck. You will not be able to tension the abductors, so that can cause instability of the hip joint. And then the reduction of the gap requires extra measures, like extra lagging, extra impaction of the shaft against the head. Thank you very much.
Thank you, Dr. Gourineni, for this wonderful talk. Next speaker I will introduce is Dr. Courtney Selberg. She unfortunately is on call, so her talk is pre-recorded. She recently joined the University of Cincinnati Children's Hospital as co-director of their child and young adult HIP program. She is going to share with us her experience with a delayed modified Dunn procedure done after in-situ fixation.
Thank you for the opportunity to share our work today. I'll be discussing temporary in-situ pinning with subsequent modified Dunn as a safe alternative to primary modified Dunn. I apologize for not being at the webinar in person. I am on call, and so I have pre-recorded this talk. Myself and my co-authors have no financial relationships to disclose. However, these images and animations were created in my previous role at Children's Hospital Colorado, and that copyright is owned by Children's Hospital Colorado and their animation department. I very much appreciate the use of these for this specific presentation. So we know that slipped capital femoral epiphysis is characterized by translation of the capital epiphysis from the metaphysis through the physis. Historically, in-situ fixation did report reasonable Iowa hip outcome scores. However, with this in-situ pinning, looking at patients in the long term, their patient-reported outcomes do worsen with increasing severity of the slip. And this resulting complex three-dimensional deformity shown here can create femoral acetabular impingement, obligate external rotation of the limb, and significant restriction of hip joint motion. The modified Dunn osteotomy using a Gone surgical hip dislocation approach is our treatment of choice for those with a moderate and severe slip, really allowing anatomical restoration of the proximal femur, as well as direct inspection and preservation of the physeal blood supply. This complex procedure has been reported on by several groups after its inception, and given the complexity and potential for complications, most experts would agree that this is best performed in a specialized center with an experienced team. The modified Dunn procedure, it is a viable treatment option for moderate and severe slip. However, an experienced hip surgeon may not be immediately available. However, no prior studies have really evaluated whether performing an initial in-situ stabilization followed by staged modified Dunn reconstruction later in the subacute setting has an impact on outcome. Therefore, the purpose of our study was to compare both clinical and radiographic outcomes after primary modified Dunn versus in-situ pinning followed by staged modified Dunn. In other words, we wanted to answer the question of whether or not temporary stabilization compromises the results of modified Dunn surgery. Animation depicting a modified Dunn surgery. We start with a trochanteric osteotomy standard to a surgical hip dislocation. We then perform our capsulotomy, followed by a second trochanteric osteotomy to assist with the periosteal sleeve dissection and protect the retinacular vessel shown here. We then separate the metaphysis from the epiphysis and reshape any callus that is formed as a result of the chronic slip. Finally, we fix the epiphysis in its anatomic location with cannulated screws, as shown here. After the epiphysis is reduced, the capsule is closed following screw fixation, as well as fixation of the trochanteric osteotomy. The institutional algorithm that we use at our institution is if a hip surgeon is available, then a primary modified Dunn would be performed. However, if there's not a hip surgeon available, in-situ pinning is performed by the on-call surgeon, with modified Dunn being performed 2 to 4 weeks later, depending on surgeon and OR availability. If there is any chronicity to the slip, often a CT was performed in this setting to ensure that there were no significant bony bridges forming at the physis. There was also the opportunity in this second group for the surgeon to discuss with the family risks and benefits in a subacute setting. Here are our methods. We followed a consecutive series of patients treated with modified Dunn surgery at a single institution between 2017 and 2022, 15 in the primary modified Dunn group and 14 in the staged group. This included a total of 29 patients in both groups, and patients were excluded without follow-up greater than 1 year. The data was analyzed for both radiographic and clinical parameters. In regards to our results, there were no significant differences in any of the demographic parameters between groups, including slip angle or stability preoperatively. The average slip angle in both groups was right around 50 degrees, and the vast majority of patients were considered unstable based on the Loader classification. The average time from in-situ stabilization to primary modified Dunn was 27 days, with the average follow-up nearly 20 months. There were no significant differences in complication rate, including AVN rate and implant failure. However, I do want to point out that there was a significant difference in both blood loss as well as length of surgery, with the in-situ converted to modified Dunn group being slightly higher on both of those parameters. I think a big reason for this is there already was either one or two holes in the proximal femur, and certainly that makes the screw trajectory a little bit more difficult for final fixation. So that was really the biggest difference we saw in between these two groups. There were no significant differences in any of the radiographic parameters, including tonus grade, Southwick angle, alpha angle, or neck shaft angle at final follow-up between the two groups. We did demonstrate that both patients really ended up in a fairly anatomic situation in regards to the anatomy of their proximal femur. The two groups also had no significant difference between their range of motion outcome at final follow-up, as well as their clinical outcomes in terms of pain, mobility, and walking score. Here's an example of a 3-year outcome of a patient who presented with a severe unstable slip. Initially, this slip was pinned with the on-call surgeon as there was no hip surgeon available at that time. The modified Dunn was performed 14 days later after meeting with the family, obtaining a CT scan to demonstrate there were no significant physeal bridges, and ensuring that the patient's understanding of the procedure was adequate to proceed. In summary, there were no differences in complications between groups. There were differences in blood loss and length of surgery, with the in-situ and modified Dunn group demonstrating slightly more blood loss and surgery times. There were no significant differences in radiographic or functional outcomes between groups at intermediate follow-up. Therefore, besides our slightly longer surgery times as well as higher blood loss, temporary in-situ pinning does appear to be a safe alternative to primary modified Dunn. This approach does also allow patients and their family more time to consider the risks and benefits of modified Dunn, as well as the extended recovery time prior to proceeding. It does also give the surgeon time to do this on a semi-elective basis during normal working hours and with an optimal surgical team, which I find to be a high priority. It also does allow the surgeon time to get to know the family and ensure they can comply with postoperative precautions that are very important for minimizing complications. Finally, there are limitations to this study. There's only intermediate-term follow-up, a small sample size with 29 patients, and retrospective data. We do acknowledge that the study may have been underpowered to definitively draw this conclusion, and further investigation is definitely recommended. Special thanks to all those who were involved in this study, including my amazing research team at Children's Hospital Colorado, who made this work possible. Obviously, I'm no longer with them, but I'm very impressed with all of the work they did on this study. I thank you for your attention. I'm happy to answer any questions during the discussion portion.
All right, and with that, thank you to Dr. Selberg for her presentation. We have a question from the audience. Dr. Ziebarth, the attendee, is asking, can we do Dunn procedure with the Smith-Peterson approach?
You know, that's the problem, and what made at the beginning such a bad reputation for this modified Dunn procedure, because everybody wants to modify all these established approaches, and when you do the modified Dunn procedure, you have to be as close to the vessels as you can be, because you want to preserve them. If you come from anterior, you have no chance to sufficiently and safely release the periosteum. And of course, in very young children where the periosteum is very thick, you can try to mobilize the periosteum. But if you want to have a really low rate of AVNs as a complication of mistakes from the operation technique, you should do the safe surgical hip dislocation.
Thank you, Dr. Ziebarth, for that answer. So with that, we're kind of going to switch gears a little bit from talking about addressing acute SCFE to some of the techniques that we could use to deal with post-SCFE deformity. And with that, I'll turn the discussion back over to Dr. Gourineni to discuss the arthroscopic management of FAI.
Thank you again. So arthroscopy in SCFE has been described since 1992, right? Our paper in 2014, we had about 40 cases, but Lunik published before us a three-case series. So the remodeling in a SCFE, I don't think it's a real remodeling. It's a neck prominence that gets worn out at the expense of damage to the acetabulum and the labrum. abrasive damage. Here you can see this fragmentation of the neck, and you can see the remodeling of the acetabular lip from this convexity rubbing on it. This is how a mild SCFE with raw bone can actually abrade the undersurface of the labrum and the articular cartilage. And more severe synovitis in different cases with acetabular damage. So even mild SCFEs do a lot of damage. So based on this observation, we have an algorithm or a classification based on clinical classification. The mild are rare SCFEs with no impingement at all, good range of motion and mild SCFE. They get an in-situ screw. Anybody with a little more than a mild SCFE but impinging a little bit, right? We call them a moderate. They are correctable by osteoplasty. So these are our moderate group where screw and osteoplasty is the treatment option. And anything more severe, it's an osteotomy for correction. So osteoplasty indication for us are a mild degree of slip with impingement. And clinically, the deformity should be about less than 20 degrees of obligatory axial rotation. And your osteoplasty, typically osteoplasty of the neck gives you about 40 to 50 degrees of correction of the alpha angle. So if the alpha angle can be corrected in a way that the internal rotation can be increased to plus 20 degrees, which is more normal, then we offer osteoplasty. The goal of surgery is to prevent further damage, improve internal rotation, and the way to figure out if you can do an osteoplasty is the alpha angle change on the X-ray measurement minus the deficit of internal rotation of 20 degrees gives you the post-op internal rotation. Here's a case example. Again, a 12-year-old female. The slip angle made about 46 degrees, but her clinical deformity is minus 20. So minus 20 of internal rotation clinically. So when I draw my lines, that's the neck axis through the center of the head. That's the pre-osteoplasty plan. The alpha angle here will be about 120 degrees probably. This is the post-operative. The alpha angle comes down to about 55, 60 degrees. So I'm getting this much correction here, and it will easily correct the minus 20 to plus 20. That's the estimation. This is an arthroscopic view where there's damage from that bony bump against the acetabular cartilage and the labrum. So this is the osteoplasty done. The alpha angle now decreased way down, where clinically her internal rotation improved to about 20 degrees plus, and she maintained that rotation without any symptoms for about 5 years of follow-up. Second example, another 12-year-old, mild slip on the right side, very mild, minimal deformity, minus 10 degrees of internal rotation. Same option. Some of you may not approve this, the trajectory of the screw, but we published on this 2 papers that did not change people's practice. But oblique screw is fine. You don't need to be perpendicular in our opinion. It can be posterior, allowing osteoplasty. And this patient healed well and maintained his range of motion. A last example. This patient had a little more severe deformity, 30-degree deformity. So I said 20 is my indication, but it's 30, but has acetabular overcoverage. So we had some room to remove bone on the acetabular side. So here we did acetabular rim trimming, label repair to get another 10 to 15 degrees up at the rim level. Then did the osteoplasty on the neck level and were able to correct his deformity and got enough internal rotation. In conclusion, arthroscopic osteoplasty has been quite safe in our hands. It prevents further damage if you do it early enough. I think it's a good option in mild to moderate deformities when adequate internal rotation can be obtained by osteoplasty. Thank you very much.
Thank you, Dr. Gourineni, for that wonderful talk. Next is Dr. Pablo Castaneda, who trained as one of the first fellows at Texas Children's Hospital. And he then went on to New York to lead the division of orthopedic surgery. But he's finally now come home back to Texas Children's Hospital to lead our division of international and destination surgery. He'll discuss with us when arthroscopy is not indicated for post-SCFE deformity.
Thank you, Basel, for that introduction. And thank you, Basel and Daria, for organizing this and moderating, and to SICOT for allowing us the opportunity to share knowledge. This has been a fantastic webinar, and I hope that I can live up to the expectations, talking about when arthroscopy is not indicated, as you've just seen from Prasad. In the hands of someone who is an expert arthroscopist, you can take care of a lot of the deformity that occurs, but it's not always the case. And in my view, the ultimate way to view the joint, so arthros from the ancient Greek, joint, scope to see, is the surgical dislocation. And I will give full credit to the group in Bern, and specifically Professor Gans, for describing the approach, which has allowed us to safely access the joint and allowed us to take care of most of the intra-articular pathology. Before I get into the surgical dislocation, I will mention one other possible option, which is the mini-open anterior approach, which has also been proven to be safe and effective, especially when you have a limited amount of deformity, because you can do the same interval you would use for an anterior approach. You see the rectus femoris being retracted medially and the tensor fasciae lata being retracted laterally. And by placing these retractors, you can actually expose the joint from the anterior aspect through a relatively small incision in relatively skinny patients. If you put a bump under that side, you can then take a high-speed burr to correct the cam deformity on the femur. And the nice thing about this, as opposed to one of the limitations of arthroscopy, is you can truly take the hip through full range of motion. I know that with some tables, you can take the hip through range of motion, but that's been one of my difficulties in doing arthroscopy, is taking that hip through a full range of motion to mimic the real site of the impingement. So I think the mini anterior approach is also a valid option in your arsenal of tools for treating FAI, since not all hips do require a full dislocation. And if you identify the site of the pathology, this can actually take care of it. But moving on to the actual technique, and full credit to Professor Gans for describing this. This is, as Kai eloquently showed, an approach which specifically respects the vasculature of the proximal femur. So with the patient in a lateral approach, a modified Gibson approach, you split the fascia lata in line with the skin. And to me, one of the most crucial steps is identifying the trochanteric branch of the MFCA, the medial femoral circumflex artery, which supplies the blood supply to the femoral head. So by identifying the short external rotators, you can identify the trochanter, and then taking advantage of the aponeurotic continuity between the gluteus medius with the asterisk on the left and the vastus lateralis with the circle on the right, you can identify the troch, and you can see those vessels as they come up. So that's the key to protecting the vasculature to the femoral head. And you then proceed to do your osteotomy. Another trick, if you're struggling with identifying this, is to actually take an X-ray at this time to make your osteotomy, especially as you begin to do this procedure, so that you don't take too much of a piece or too small of a piece from the osteotomy. At the time of doing that osteotomy, you will then identify, as again eloquently shown, the most important landmark, which is the piriformis. And you can place your finger on the piriformis tendon and feel this very clearly, which allows you to know where that marker is to not continue your dissection any further lateral or posterior to that. You can dissect further medially without much risk to the femoral the blood supply to the femoral head, but not posteriorly to that piriformis tendon. So here is the clinical picture showing the piriformis tendon at its insertion just above the greater trochanter. And by exposing that, you now have full exposure to the capsule. I advocate doing the capsulotomy as described classically by the group in Bern, with a Z-shaped capsulotomy, with one going along the rim of the acetabulum, coming down the epiphysis, and then towards the neck, by internally and externally rotating the hip. That allows you to identify the joint, and you can clearly identify the portion which is non-spherical, the cam deformity, and identify the labrum. Again, if you do a relatively small approach, you can identify the vast majority of the post-SCFE deformity, which tends to be in this region, anterior and lateral. So you can identify this and treat that portion of the deformity in an isolated way. But one of the nice things about doing this in an open fashion is you can flex the hip up to mimic the patient's symptoms, and then you see the actual impingement and the damage that can be caused to the labrum. To complete the dislocation, you rotate the hip and release the remaining tissues. And the advantage of this is it truly gives you full visualization of the joint, which you cannot get in any other way. This allows full access to the rim of the acetabulum, the depths of the acetabulum, and the femoral head. So you can then take an osteotome and trim down that portion of the head-neck junction to restore the spherical congruity. And I love using the sphericity templates, which allow you to identify exactly where the extent of the loss of sphericity comes from. So, as with any surgical procedure, its success depends on it being reproducible. There is no point in describing a procedure that only you and perhaps one other person in the world can do. So we designed some research around this. Is surgical dislocation, osteochondroplasty, and labral repair for femoroacetabular impingement in adolescents safe, effective, and crucially reproducible? So we did a retrospective review of prospectively collected data. This was a dual center study with two surgeons. One was myself and the other was a former fellow of mine who learned the technique from me with a minimum 2-year follow-up. And we were able to match 46 hips with femoroacetabular impingement at a mean age of 15 years. 2/3 of them were boys and 1/3 were girls. The symptoms had been present for approximately 12 months, and most were CAM type, as this was mostly post-SCFE deformity, but there were a couple of pincers and mixed. Of note, 43 of the 46 patients had labral tears, and all underwent repair at the time of surgery. So these are pictures from my technique. This is the step cut that I now perform in the trochanter, which allows a very stable fragment when you're repairing. And if you're not doing any trochanteric descent, I love doing this technique because it gives you a very nice stable fragment of the greater trochanter. Then you can flip that trochanter anteriorly, again respecting that continuity, and then expose the femoral head and identify that loss of offset, loss of sphericity. So I love using these templates. You can then roll these around the head, and you can see here how that head is out of round. So by taking a combination of curved osteotomes and then the burr, you can trim this down to restore a more spherical congruity between the femoral head neck junction. And again, you can see in the back how you can identify the labrum and truly work in a 360-degree fashion around the joint. So here you see the labrum, and you can see into the depths of the acetabulum. So this provides you full access if there was any need for any chondral work. And in this case, we have done a full repair of the labrum using circumferential anchor fixation, as this one was found to be a pincer. So we also did a recession of the acetabular rim, a rim trim, and a reattachment of the acetabulum to restore the normal biomechanics of the hip. And this, I don't think, could honestly be done safely with as good visualization arthroscopically as well as you can surgically. And I was taught that wounds heal from side to side, not lengthwise. So the fact that you have a 15-centimeter incision doesn't really worry me too much. So we looked at our patients and we measured the mean Harris hip score preoperatively and then subsequently at weeks, months, and a year and 2 years afterwards, analyzing pain using the visual analog scale and radiographically measuring the alpha and center edge angles. As mentioned, most of the patients had an MRI and were identified to have a labral tear, and when that was the case, they were all repaired. And this is the typical result you can see after a rim trim and the trochanteric repair, which again is very stable. So our results showed that the visual analog scale of pain went significantly down from a preoperative mean of 6.6 to less than 1 at 2 years. So excellent result as far as relief of pain. and maintenance of function. The mean Harris hip score went from a mean of 78 to a mean of 93 at 2 years. So the patients are functioning at a very high level after this procedure. I only included the alpha angle because most of them were cam-type deformities. The mean deformity went from 58 to 48, so a significant difference on all objective measures. We had no cases of AVN, no major complications, and no significant differences between the two centers. So our conclusion is that surgical dislocation for the treatment of primary FAI and post-SCFE FAI in adolescents can reliably reduce symptoms, improve function without significant morbidity. So we believe this is a safe, effective, and crucially reproducible technique in treating FAI in adolescents. Thank you very much.
Thank you, Dr. Castaneda, for that wonderful talk. And I'll turn it back over to Daria, who will introduce our last speaker.
Yes, we are now moving to the last speaker, and which will given by Michael Petrov. He's head of the pediatric service of children's traumatology and orthopedics of Ilinsk Hospital. Michael will demonstrate a clinical case and tell us about the role of endoprothetic in treating AVN after slipped capital femoral epiphysis. Should I and when? Michael, we see your screen. You can start.
Нет у тебя звука. Где? Нету звука вообще. Ни микрофона, ничего. А вот слышно меня?
I can hear you as well.
Do you hear me? Yeah, yes. And what about my presentation? Do you hear? Do you see?
Yeah, we can see it now.
Yes. Thank you very much. Thank you very much, because I see some problem. Okay, good afternoon. Today I will discuss the role of arthroplasty in the treatment of avascular necrosis following slipped capital femoral epiphysis. This is final stage of unsuccessful treatment, but essential to have this option available. The main indication for arthroplasty are pain and significant functional limitations that cannot be eliminated by conservative method or other surgical treatment. In other words, arthroplasty is the last resort when there are no other surgical option available. This slide and the statistic is not very accurate. In fact, arthroplasty are only indicated for avascular necrosis. Avascular necrosis can develop as a result of various pathology, including slipped capital epiphysis, and with treatment. This slide shows options according to the literature. An important note that the incidence of slipped capital epiphysis is low, above 3%. This may indicate that treatment outcome improved and the significant avascular necrosis doesn't often develop on this disease. The result of arthroplasty shows significant.
Can you change your next slide? Next slide. We don't see your next slide.
You don't see my slide, and this?
Next slide. Can you open next slide?
Just a moment.
Probably go to full view.
Right now, do you see?
Yes, it's better.
Okay. The result of arthroplasty shows significant improvement in functions and quality of life of patients according to most common assessment scales. The follow-up period of this article is about 8 years. The total risk of complications, including the need for revisions, which will be discussed in the next slide, was 50%. Among these complications, infections, complications, and limb length discrepancy warrant particular attentions. In one case, limb length discrepancy required revisions. Dislocations are generally less common in young people than elderly patients, which related to muscle balance. The most common reason for revision arthroplasty is prosthesis loosening, which happens over 50% in case during the first 3 years. Other causes
Please open next slide, Mikhail. Next slide, please.
And right now, do you see?
Yes, thank you.
I'm sorry. Loosening is most common reasons for revision arthroplasty. It happens on 50% at the 3 years. The average of revisions in adolescents, it's about 12 persons over 7 years follow-up. Historical data show higher revision rate in past, but modern improvement included 25 years ago, cementless fixations and ceramic pairs have reductions with rates to 4 persons in like in adult patients. Let me present a long case of treatment of patients with slipped capital femoral epiphysis, which I call it lasting a lifetime because it was very long and very difficult for patients and for doctor. This case Belgian with a very large boy with BMI about 27 at the time of onset. When the boy 11 years old, after jumping for low height, he complained a pain in his left leg and was taken a clinic who treated acute injuries in children. An X-ray showed epiphysiolis, which was interpreted as traumatic. According to medical report, the boy underwent surgery, specifically closet reduction and fixation with 2 screws. For some reason, X-ray of a second joint were not taken. Apparently, this situation was classified as injury. An X-ray both joint was taken for first time at one month after the operations. No pathology was detected on the other side. There was no mentions or preventative fixations of the right side. 1 year after operation, the boy turned 12, and after X-ray, a decision was made to remove the screw. There was no epiphysiodesis, and the logic behind this decision is unclear to me, but it's happened. After 6 months, complaints of pain on the right leg's apparatus, and the X-ray was performed. A CT scan was even performed too, which we will return to later, but for now, a strange choice of treatment was made, in my opinion. Fixation performed on contralateral side. On the left, the growth plate will still visible after primary operation. I would like to return to CT. If we evaluate the channel from the removed screw, we can see what the channel in femoral neck and the femoral head do not match. This confirms once again what the process of epiphyseal slippage is continuing. On the X-ray, the taking 6 months after fixations, it's clearly visible what the displacements of epiphysis is progressing on the left side. If we compare the X-rays, the progressions of displacements on the left is clear. At the same time, the patient's not clinical sign of unstable epiphysiolysis on the left side. At this point, the patients underwent open reduction and fixation with 2 screws. The X-ray after 3 months, everything looks fine and at first glance, but 1 year after operations, 1 year after 6 months later, the pictures so not optimistical but quite logical. It's clearly evident that necrosis of femoral head is progressing and the size of head is decreasing with migration to screw into the joint. 9 moved after open reduction. Avascular necrosis is evident on the left side, migrations of screw into joints, constrictions at joint space. The screw were removed. During the course of treatment, the patient turned 15 years old, and let me remind what started. He was 11 years old. Clinical pictures: severe contracture on the left hip joint, and the right side the contracture is not as severe. X-ray almost complete absence of a joint space of the left side, and femoral head significantly deformed. Essentially, with such a clinical and radiological pictures with severe pain syndrome at this age, were probably no other options other than arthroplasty, which was done. After the patient came to our clinics, we performed a total replacement of left joints. At this time, we gave preference to cervical and prosthesis, taking into the child age. Rehabilitation was very difficult, lasting more than 1 year. The person was satisfied with the functional outcome, had no pain, and did not return 1 year. 2 years later, the patients returned for follow-up examination and discussed possibility to replacement the right hip joints. The range of motions in the left joint was satisfactory, but recent months he had noticed discomfort and pain. Repeat X-ray showed loosening of the femoral component. As I said at start, this is most common reason for revisions in the teens. The exact cause is unclear. It's maybe related and growth of expansions of femoral necks, or is a result of aggressive and prolonged rehabilitations. But fact is the situation requires of revision surgery. Therefore, instead of replacing the hip joints, we performed revisions and revisions arthroplasty of left hip joints. At standard prosthesis was used for this procedure in this case. Rehabilitations in this case was simple and quick. Follow-up result at 2 years later showed the prosthesis was stable. And the patient's now 21 years old. He refused to have his right hip joint replacement because he's satisfied of a range of motions. He has lost weight, and his BMI right now is 21. The only complaint he has in rotations deformity in the right side. And we are not recommended a replacement of right side because this is no pain syndrome and no active complaints. I should be noted that we are not sure what's the treatment of this patient in final, and no operations or revisions will be required. It's why this is a lifelong case. In conclusion, I want to tell that total hip arthroplastic not indicated in case of a slipped capital femoral epiphysis, but indicated in case of vascular necrosis with pain syndrome and severe joint contracture. I think the total hip arthroplasty is not good choice for young patients, and this is final stage of unsuccessful treatment, and I think this is last resort when there are no other surgical options available. Thank you for your attention, and I'm sorry for my technical problem.
Thank you, Dr. Petra, for this wonderful talk. We have a question from the audience, and it's in general, the question is, when approaching FAI in adults, do experts advise arthroscopy or surgical hip dislocation if you're not an expert hip surgeon?
Would you like me to take that, Basil?
Yeah, please go ahead, Dr. Castaneda.
Yeah. So I think the question is an excellent one, and the answer is not an expert hip surgeon, because these procedures are all dependent on your level of expertise. As Dr. Gourineni showed us, arthroscopy is excellent in the hands of someone who is a good arthroscopist. And as Dr. Ziebarth and Dr. Gans have shown us, open surgery is excellent in the hands of someone who is an expert doing that. My advice would be to actually start with an anterior mini-open approach, which I think is actually the easiest and most reproducible, which requires the least amount of extra equipment. You don't need a special table. You don't need any real special skills. And if you can do an anterior approach to the hip, which most pediatric orthopedic surgeons can do, then it is the safest approach. Now, having said that, it doesn't give you the access that arthroscopy or surgical dislocation gives. So I would suggest to start with a mini-open anterior approach, and then leading from there to gaining more expertise with any of these techniques.
Thank you, Dr. Castaneda, for that answer. Dr. Gourineni, in your view, who is the ideal patient for the arthroscopic assisted modified Dunn?
Somebody who's thin, not obese, somebody who has a long enough neck that I can retain at the end of the wedge resection, because instability is my main concern. Everything else can be overcome, but instability after fixing the head from a short neck or obesity is the main concern. So a thin person with a long enough neck will be the ideal patient.
Thank you for that answer. I'm looking here. Are there any further questions from the audience? Okay, we don't have any further questions from the audience. And with that, I'd like to thank all of our wonderful speakers for their time and sharing their expertise. And I'll turn it back over to Al for the conclusion. And I want to thank him so much for his leadership in our committee and the efforts that he's putting in.
Yes, thank you very much, Basel and Daria, for moderating this session. As many of you may have noticed from this webinar, we do not stick to the usual modalities of treatment for SCFE. We try to put in this webinar newer and emerging technologies so that it will stimulate many of you who are attending this webinar to look further into these emerging techniques and technologies. On behalf of the SICOT Pediatrics Committee, I thank all of you who attended this webinar. I really must appreciate the efforts of all our stellar faculty who have devoted their time and efforts in sharing their expertise with all of us today. It's been a wonderful learning experience for me, and I'm sure all of you attendees have benefited from this interaction as well. Thank you very much for your presence here today. Goodbye.
Thanks, everyone.